Hi, my name's Owen Kalaki, and I'd just like to start this webinar on sexual health and youth mental health with an acknowledgement of country. So I'd like to begin by acknowledging the traditional owners of the land on which we meet today, and I'd also like to pay my respects to elders past and present. So now it's my pleasure to introduce Dr. Brian O'Donoghue. Brian is a consultant psychiatrist and a clinical research fellow at Orygen, the National Centre of Excellence in Youth Mental Health. And he leads a multidisciplinary team in providing treatment for early psychosis to young people. His research interests are in the delivery of effective treatment for psychotic disorders with minimum side effects or harmful effects. He completed his medical degree at University College Dublin and obtained a master's degree in epidemiology and public health from the University of London. In the last couple of years, he received a PhD again from University College Dublin, and he's now co-authored or authored over 50 publications in youth mental health. So it's my great pleasure to welcome Brian to talk to you about this today.
No, thanks very much, Owen, and everyone's very welcome to the presentation. And I'm going to address today, look at the sexual health of young people with mental health disorders. And my interest for this really stemmed from something that we saw quite frequently in clinical practice. And it had a big impact on young people's quality of life, their relationships, but also had an impact on their engagement with treatment for a variety of reasons, which I'll outline in the presentation. So we also looked at whether we could address this, whether it could have multiple benefits in their day-to-day life, but also as well with their engagement in treatment. I'd also like to acknowledge the contributors to this presentation, Catherine Monson and also Dr. Ahmed Bajouri from Orygen Youth Health, produced a number of the slides here. And also I'm going to talk about the results of a study that we conducted at Orygen Youth Health. And I'll mention everyone in the team after the presentation, but two medical students at the time, Elizabeth Macmillan and Aziel Adan Sanchez, conducted a number of the interviews and put together the papers that I'll be presenting a lot of the findings from those research projects. So as a general outline, I'm going to talk about sexual health and why it's important. I'm going to talk about sexuality and sexual identity, and also talk about gender identity. And I'm going to briefly mention the role of sexual trauma in mental health disorders. That in itself could be a webinar, so it's really going to be kind of a brief overview. And I'm going to focus on two areas of sexual health, one being sexual dysfunction and the other one being high-risk sexual behaviours. And I'm going to talk about screening and then some further resources that clinicians will be able to access. And as I mentioned, I'm more than happy to take questions throughout. And what I might do is after each section, we'll check and see if there's any questions. So please email them through, type them through. So the first question is, what is sexual health? And if we look at the World Health Organization's definitions, it's a very broad definition, and it encapsulates a number of different factors of people's lives. So it's defined as a state of physical, emotional, mental, and social well-being in relation to sexuality. And it's not merely the absence of disease, dysfunction, or infirmity. And sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences free of coercion, discrimination, and violence. And for sexual health to be attained and maintained, the sexual rights of all persons must be respected, protected, and fulfilled. So you can see it's quite a broad area, and as I mentioned, we'll probably focus on a few aspects of that, mainly kind of sexual dysfunction and high-risk sexual behaviours. And then if we look at why youth mental health, well, and why look at this topic in young people, and this is a slide that we use quite a lot at Orygen. Really what it just signifies is that the main burden of illness for young people is related to mental health disorders. So you can see there, essentially the main age that the onset happens is in the adolescence and early adulthood, is when people develop mental health disorders. And if we look at, well, why is it important and what's the connection with sexual health? Well, we know that adolescence and early adulthood is the time of development of intimate, romantic, and sexual relationships. And also it's a time of exploration of people's sexual identity, sexual relationships, and also it's a time also of risk-taking behaviours as well. It's also a change in the sense of self and the primary relationships, moving away from the family being primary relationships to peers and also intimate partners. We also know then there can be an increased time of our time of increased vulnerability as people engage in these relationships, engage in kind of intimacy and also sexual activities. But most importantly, when we ask young people what their priorities are, what they want assistance with, they talk about relationships, they talk about sexual health. So this is a issue that's important to young people. And within the mental health services, we know that young people don't necessarily engage with their GPs or other healthcare professionals or attend sexual health clinics. So also if a young person is attending a youth mental health service or mental health service in general, we know this is an opportune time to address their sexual health and both looking at it in a positive way, but also looking to see if there's any areas of vulnerability as well. So if what we'll talk about now is, I suppose, terminology that's been used and looking at for sexuality and gender identity, and to look at why should we talk about this with young people and why should it be an important factor. If we look at sexuality, it's important to identify that it's a broad term and it can mean lots of different things to different people. But there's essentially three components to it. The first one is how someone identifies, so their kind of sexual identity. And then there's also another thing, which is who they're attracted to, the group of people that they are sexually attracted to. And there's also then sexual behaviour, so the acts that people carry through with. And what's important is that there's different terminologies for sexual identity, but it doesn't necessarily mean that all of those three different aspects are going to be the exact same for each person, for example, who identifies as gay. So when you're talking with a young person, it's important to address all these areas and ask specifically about each of these, because it will be different, and it's again the terminologies that we tend to use don't cover all of these. So when we talk about sexuality, there's different terminologies that can be used, and people use their own terminology, such as gay, lesbian, bisexual, pansexual, heterosexual, or asexual. And these terms here, this list is not exhaustive. And what's very important when we talk about sexuality, people, is we ask very open questions about it. But the most important things to ask is what that means to the person. So, and this applies also to gender identity. So I'll talk about that now. So it's an important thing when we talk about gender. This is a term that's used to refer to the characteristics that society allocates someone based on their birth sex. And there's different, again, terminologies that can use this, and it's highly individual and dependent on the person's preference. So we male, female, cisgender male or female, non-binary, trans male, trans woman, trans man, trans woman, gender queer, gender non-conforming, gender questioning, gender fluid. And again, I think what's a very important factor with this is that we don't assume that we know what those terms mean, because it's very individualized. And I think the best approach with it is when you're talking to young people about your gender identity, is to ask very open questions such as how do you identify in terms of your gender, but then to ask what does that mean. And as a clinician, don't be embarrassed if they use terms that you're not familiar with, or even if you think you know what that applies to, maybe clarify with the young person, because the feedback that we've received from young people is that they want to be able to describe it and to not use any assumptions. And the other thing is that this list of terminology is being updated and changing rapidly, and I think it's very difficult to actually keep your finger on that pulse. And the best way around that is actually to asking people what do they mean when they use that term, what does that mean to them, in a very kind of open, respectful way. And to ask the question, why is it important then that we address this and acknowledge it? Well, firstly, it's about making it being inclusive and making people feel comfortable within the services that they attend. For example, in a number of services, people traditionally on their if they have a file, the stick it on the file might only have two options, which is male or female, but a person may actually then express to be they wish to be known as a different gender. And I think again, if a service is too rigid in their response, that could alienate a number of young people attending the service and potentially actually stop them actually attending and engaging within that service. And as mental health services, it's really important that we are very open and accessible to young people who identify as either lesbian, gay, bisexual, or of diverse sexual identities. Because we know that this group are twice as likely to experience a high or very high levels of psychological distress in comparison to non-LGBT peers. And we know that people who identify as LGBT experience mental health disorders at least 2 to 3 times that of other people in the community. And self-harm and suicide attempts can be related to homophobic or transphobic abuse that they experience. So in fact, our very service that we have should actually be designed to really cater for this group of people, because we know that they're at much higher risk. So we should be, again, focusing on accessibility and making the service very open and engaging for this group of people. Most importantly, what we want to do is ensure that we don't perpetuate exclusion and discrimination. If we look at the role of sexual trauma in mental health disorders, and as I mentioned, this is a topic in itself that could be a webinar. So I'll just touch on it quite briefly, really. And we know that a number of types of abuse are risk factors for developing mental health disorders, and sexual abuse is one form of that, and it often accompanies other types of abuse such as physical abuse, emotional abuse, physical and emotional neglect. And also it's very difficult to distinguish the roles of these factors, because we know that people who develop mental health disorders can also be vulnerable to abuse, but also that the abuse itself can lead to increased risk for mental health disorders. So I've just got a question here, which is very good, by to explain and talk about pronouns and how to ask about them. So one of the things that we've done within Orygen Youth Health is actually ask people how they would like to be referred to. So again, we certainly shouldn't assume that about people's sexual identity or gender identity, and then with that, we shouldn't assume that people are happy or content to be referred to as he or she, because often people may wish to be addressed in a neutral pronoun, and if this is the case, with my opinion, that's how we should address them throughout the time, and that may not be just about directly related when you're relating with the individual. Even when their case has been reviewed at clinical team meetings, in medical notes, out of respect to them, we should use the preferred pronoun, their own preferred pronoun. But I think these are things that need to be discussed at service levels as well, because if a young person expresses to maybe their clinician that they want to be referred by a particular pronoun, there needs to be a mechanism to ensure that this gets carried through across the service, so that by the receptionist, by other clinical staff, that there's consistency and there's a way of communicating that. Because it'd be very difficult for you person to have to consistently, it'd be very frustrating for them to have to consistently repeat that message. But it's a very good question, and likewise, please do send in questions as we go on. Looking back at the, and again, what this slide is, this really is a slide just to demonstrate the mental health disorders that are associated with, that have an increased risk when there's a history of sexual trauma. And really, I think you could nearly pull up a picture of the DSM, because essentially we know is that the vast majority of mental health disorders is that sexual trauma can be a risk factor. So it seems to be a general risk factor and vulnerability for developing mental health disorders. And we're going to talk about more of these in detail when we talk about the results of the study that we conducted at Orygen Youth Health. Again, just to mention specifically, in terms of psychosis, we know that people who have a history of sexual abuse are nearly 2.5 times more likely to develop psychosis in comparison to people without a history of sexual abuse. And those young people who we've identified as being at high risk for psychosis, when we look back, or when they were followed up longitudinally, it's found that those young people who had a history of sexual abuse were more likely to go on to develop a psychotic disorder. But essentially, as mentioned in the previous slide, it seems to be a general risk factor and move across really all the mental health disorders, depression, personality disorders, psychotic disorders, and also particularly with substance use as well, which has a strong connection across the mental health disorders. So now we're going to talk about, I suppose, is one of the two factors which we'll focus on in more detail, which is sexual dysfunction, and then after we'll talk about high-risk sexual behaviours. But sexual dysfunction is it's an umbrella term, essentially for one or more difficulties relating to sexual desire, arousal, erectile response, genital pelvic pain, orgasm, and ejaculation. For it to be defined as sexual dysfunction, I mean, this is the definition that's used medically. It needs to be present at least 75% of sexual experiences, at least for 3 months, and to cause individual distress. Now, again, we want to obviously address these things early. So, for example, someone might develop sexual dysfunction early on in the course of treatment. So you wouldn't wait 3 months till you diagnose it or do something about it. But that's in terms of the kind of definition that is used for sexual dysfunction. And why it's important, and why kind of I suppose this is going to be one of the focus of the webinar, is because we know this is a common but yet overlooked experience in people with mental health disorders. And the vast majority of the research to date has been conducted in the adult population. And has tended to, and therefore not include young people. And also it's tended to just focus on one mental health disorder in isolation. So it tended to take a very specific group and also really look at just one diagnostic group, depression or psychosis. And the other thing that's important is that the prevalence rates of sexual dysfunction, so how common it is, really depends on the method of how you assess it. So if you ask open questions, and if you just ask people, do you have any side effects or any difficulties, etc., the reporting is very, very low. So people don't spontaneously report it. If you use a questionnaire that has the questions and you give them a self-report, it'll increase the prevalence of it. But if you actually ask people directly and you ask very specific, clear questions, you get much higher rates. So essentially, one of the difficulties is that we've been really underestimating the true prevalence of this side effect or disorder or part of disorder because of the way that we've been assessing it. And I think that's important because, and again, I'll talk about how common we found it to be in our young people. In the general population, sexual dysfunction is associated with a number of factors. So psychological stress and anxiety. Smoking is a common factor with it because of vascular disease, but also obesity and diabetes and substance use as well. And the reason I put this up in general population is that if we look at those 5 factors, well, we know that that young people with mental health disorders are much more likely to actually have those factors, so they're at much higher risk for developing sexual dysfunction. But in addition to those kind of risk factors in the general population, we also know that depression is associated with it. The reason behind that, there's a multitude of different reasons. For example, often with depression, there becomes a lack of motivation, lack of energy, a lack of interest, and a lack of enjoyment. And that can translate over to an individual's sexual function and sexual relationships. In psychotic disorders, there can be a type of symptom we call negative symptoms, which is essentially when something is broadly taken away from the individual and that they present as unmotivated, a lack of energy. And we know that sexual dysfunction can be very common when people have negative symptoms. Then on top of all those factors, we know that actually it's a side effect of antipsychotic medication and also antidepressant medication. And I'll talk about how common in a moment. So you can see there that young people with mental health disorders, or not necessarily just young people, they have nearly all of the risk factors for developing sexual dysfunction. So it makes sense that we would expect to see high level of this disorder, but yet it's something that has been overlooked quite a lot, despite having a big impact on people's quality of life and potential kind of engagement with service and with treatment. So if we look at sexual thing, if we look at depression, as I mentioned, it can be part of the disorder, so it can actually be a symptom of the depression. And we know that before even people start treatment before they start, if antidepressant medication is a treatment that's going to be used. We know that a certain percentage of people, in around 20-25% of people, will actually have sexual dysfunction, decreased libido, or in males, erectile dysfunction. That's most likely related to the depression itself. But to add on top of that, a number of the antidepressant medications, well, actually all of the antidepressant medications essentially can contribute and cause sexual dysfunction. So the commonest ones that we use, which would be SSRIs, and they'd be the first line treatment. Actually, between 60 to 70% of people can experience sexual dysfunction. And it can affect all phases of the sexual experience, from decreased libido to delayed orgasm, being the most common symptoms. Venlafaxine, which is a SNRI, which is commonly used second line, has an even higher rate of sexual dysfunction. It's 70%, and these figures are taken from the Moseley prescribing guidelines. Again, similarly, the decreased libido and delayed orgasm, common side effects. And mirtazapine, again, which is a medication that's commonly prescribed, a region of 25%. Tricyclics and MAOIs, they're actually prescribed less commonly now, but perhaps they are prescribed in either atypical depression or if we see treatment-resistant depression. But still, the rates there are exceptionally high, 30 to 40%. Buprenorphine is one of the antidepressants that's actually not associated with sexual side effects, and that's often the medication that people will be switched to if they experience sexual dysfunction on a particular antidepressant. The thing is that it may be related to dose, so if clinically appropriate, one of the things might be to reduce dose, but again, that depends on how the person is doing clinically. If we look at psychosis, there's been a handful of studies that have been done on this in young people with psychotic disorders. And a study done in the UK by Smith et al. Found that of the cohort of people with the first steps of psychosis, that 65% of people actually had sexual dysfunction. And so nearly 2/3 of people presented with decreased libido and erectile dysfunction in males, and also in females also experience sexual dysfunction as well. What was particularly interesting about that study is that they also included young people who are identified as ultra high risk for psychosis. So these are people who haven't developed a psychotic disorder yet, but have shown maybe subtle signs of psychosis, such as psychotic symptoms like hearing a voice, but maybe maybe 1-2 times a week for a few minutes, so not at the threshold of a full disorder, such as every day. And what they found is that the sexual dysfunction was actually half the young people in this group had sexual dysfunction, and this is a group that weren't prescribed antipsychotic medication. And in addition to that, the young people who had sexual dysfunction were more likely to actually go on to develop a full threshold psychotic disorder. And why this is an important finding is that this indicated that sexual dysfunction might be an actual kind of core component of a psychotic disorder. And that would kind of give us an indication possibly of the strong kind of biological kind of component behind it. Now, if we look at, and sexual dysfunction is common in the general population, so they did look at healthy controls within that and found that 1 in 5 people had clinically relevant sexual dysfunction. And that's in a group of people in their kind of early phase, but when we look at groups of people who have an enduring psychotic disorder, so we've had possibly a number of episodes of treatment for a long period of time, the numbers become quite startling. That in one study done was that 82% of men and 96% of females with a diagnosed schizophrenia had sexual dysfunction. And again, this was, the findings of the earlier study were kind of replicated in a large European medication trial, which included 400 people, and again found high rates of decreased libido and erectile and ejaculatory dysfunction, and a similar kind of prevalence of decreased libido in females. So really kind of strong evidence that this is a very, very common problem. Despite, and there has been only been about 3 or 4 studies really addressing this, and less so in the kind of the early phase of disorder. I just talk for a second just about the mechanism of action, because we know that the main function of antipsychotic medication is that they're dopamine blockers, so they're antagonism of the dopamine receptor. in the tubular-infundibular pathway. And what happens when we essentially block dopamine there is that it gives then leads to high levels of prolactin, so they develop hyperprolactinemia. And that can develop a number of other symptoms that it can lead to galactorrhea, so breast secretions, amenorrhea, so disturbance of the menstrual cycle, and also can have an impact on bone density in females as well. And as we've talked about here, sexual dysfunction. So why is it important to address? Well, I suppose the reasons I outlined earlier, quality of life, it has a big impact upon relationships, self-esteem, but also has a big impact on people's engagement with their treatment and with their kind of adherence to treatment because of the potential side effects from the medication. And this is a quote that I have taken from a resource that was developed at Orygen from a young person who attended Orygen, who said that I do believe a whole therapy session should be devoted to side effects and how they're going to affect you and how you feel about that. So I suppose to kind of illustrate the level and the impact of sexual dysfunction, I'm going to talk about the results of a study that we conducted at Orygen Youth Health. And this study we did last year, and as I earlier mentioned, Elizabeth Macmillan and Asiel Adan Sanchez conducted a number of the interviews of the young people regarding their sexual health. And in total, we invited 163 people to participate in the study, and of that, 116 people consented. And of those, we interviewed 103 people, so we presented results and findings from those. And I think the other thing that's important to say with this study is that it took us a while, but we managed to get ethical approval for 15 and to 17-year-olds to actually consent for themselves to participate in the study. And this is something that really hadn't been done before, because the typical thing is usually that anyone under the age of 18 requires parental consent to participate in studies. But we got very good feedback from the platform group, which is a consultation group of young people who previously have attended Orygen or are current clients of Orygen, who advise us on how the service should be run, but also gives advice regarding kind of research projects. And they strongly said that if a young person had to get parental consent or guardian consent to participate in the study, they wouldn't do it. And as a result of that, that it wouldn't be a representative study, that we'd miss out on the experiences and opinions of young people aged between 15 and 18. And that was very, very powerful and persuaded the ethics committee to give us that consent or permission to involve these young people in it. So this means that it's a very representative study, and it includes the opinions of people aged from 15 to 24. So we interviewed people, just over half people were from the early psychosis service. This included 16 people from the ultra high risk for psychosis clinic, which is the PACE clinic, and also 20 people from the personality disorder clinic, the HYPE clinic, and 13 people from the mood disorder clinic. Mean age was 20. I'll talk through the characteristics in a second, but 43 were identified as male, 52 as female, and 3 were transgender or gender diverse. And 78% of the group had experienced consensual sexual intercourse. But worryingly, 45% had reported feeling forced or frightened in sex. And of those, just under half had actually discussed that with their treating team. So just to describe the characteristics of the young people who participated in the study, as I mentioned there was a lot of diversity in terms of gender identity, with 41% identifying as male, nearly 3% as transgender male, 3% as female, cisgender, and there was no transgender female. Nearly 3% were non-binary, and 2% said they weren't sure. And in terms of sexual identity, there was 54% identified as heterosexual, 25% identified as bisexual, and nearly 7% identified as pansexual, and 5% as homosexual. Nearly 4% described themselves as unsure, and there was another 4% in kind of another described other sexual identities. And I think the big take-home message from this slide and the results of that study is not to assume anything about people's sexual identity. As we see here, that it's just over half identify as heterosexual. So if we assume people's sexual identity is heterosexual, it'll be wrong nearly half the time. and that'll be very alienating for young people. So I think it just reinforces that we have to ask very open questions and ask people directly how they identify. I think the other thing that's important is that the high consent rate that was involved in the study, which meant that young people were very open to talking about these topics. So I just got a question in here. What I've spoken, which is that you've spoken extensively about sexual functions and the need for clinicians to address it. But what about the converse, the sexual pleasure? And what do you think clinicians have in helping young people to look at the positive aspects of sexual health? So I think that's a very good question. And I think certainly we can too often focus on the negative. And I think there should be a strong emphasis about that these intimate relationships and sexual relationships are potentially a very positive aspect of young people's lives. So I agree entirely with that question. For the sake of the webinar, I probably have been focusing on the more negative aspects to it, which is sexual dysfunction. But certainly these are avenues of people's lives that can give a lot of fulfillment and intimacy, and that shouldn't obviously be forgotten about. I think the question is what role do clinicians have in helping young people to look at positive experiences? I think a huge amount. I think I think people would prefer to be looking at kind of positive things and positive experiences. And I think it's certainly definitely clinicians' roles to do that within that and discuss. These relationships are hugely important to young people. So I think focusing on the positive is very important. And really, I suppose the emphasis has been more on disorders or vulnerabilities within this. And the purpose of that is really because these are things that may come up in those discussions when talking about it. But the overall aim is to actually address these factors so that people can have more positive experiences. And in this study that that was conducted last year, we also asked people about the experiences and left it very open that they could select both positive or negative experiences. Sometimes people actually can have a mixture of those experiences with sexual experiences as well. So it's never just actually that they put into brackets of positive, negative. Sometimes there'll be mixed emotions and feelings in regards to sexual experiences. So I suppose to take a message from that the slide that's currently up is really you need to ask very open questions and not assume about sexual identity, because we see here that from a large sample from people that attend Orygen, a very diverse group in terms of gender identity and also sexual identity. So what did we find? It was unfortunately quite startling in that nearly everybody who was endorsed at least one item on the sexual functioning questionnaire. Now, there's a kind of a cutoff point of 8 items, a score of 8, which essentially is defined as clinically relevant sexual function. So that means and that's the instrument we use in the study called the Sexual Functioning Questionnaire. So to endorse 8 items would actually be quite severe sexual function, but that's the cutoff that previous studies had used, so we went with that. But nearly 40% of young people endorsed clinically relevant sexual dysfunction. And that 65% have not found other people desirable, 62% have not enjoyed sex or masturbation. And do you think sometimes sexual functioning isn't asked about if people aren't in relationships, but still in a young person's life, it's still an important function, and it's important to ask about. 53% took longer than usual to become sexually aroused, and 61% of cis males were not always able to achieve a full erection, and nearly 28% of cis females and transgender and gender diverse participants say that their physical response to sexual stimulation made intercourse difficult or painful. So we can see there that actually very, very high level of sexual dysfunction in the young people that are attending the service with mental health disorders. And we did include people from across the different programs, so for psychosis or also high risk for psychosis, personality disorders, or the youth mood clinic. But again, what was very interesting was that essentially the level of sexual functioning across these programs were very, very similar, except in the youth mood clinic, which was higher, which nearly 2/3 actually had clinically relevant sexual dysfunction. The questions just come in about the questionnaire that we use, and I'll talk about it for sexual functioning, and I'll talk about it in a moment It is actually it is freely available. It was published as part of a research project, but it's attached to the research paper that it was published in. But I'll talk about that questionnaire in a moment, because there's, I suppose, a few caveats that are important with it. But thank you for that question. So we would have initially maybe thought that it would have been higher in the psychosis group, but so we were quite interested to see that in fact, it was even high. Like, we still saw high levels there, but it was even higher in the youth mood clinic. Albeit you'd have to remember that's also where we had the smallest sample within the youth mood clinic, so it's open to kind of I suppose bias because of small numbers. And we looked at the factors associated with it. And again, some of these weren't surprising, but the use of antipsychotic medication. So if people were prescribed antipsychotic medication, they were 4 times more likely to have clinically relevant sexual dysfunction. And also, they were more likely to be non-adherent with their medication. We also found that negative symptoms of psychosis were strongly associated, and they were actually the strongest factor when we kind of in analysis, when we controlled for other factors, negative symptoms came out the strongest. And also in those people with psychotic disorders who also had depression. So when young people presented with both of those disorders, they had very high levels of sexual dysfunction. But also was interested, someone asked previously about subjective emotions around sex, and in the paper that I put up previously, we asked a lot about subjective experiences around sex. What we found is that if people had sexual dysfunction, they had much more negative subjective experiences when they had sex. So again, this was a kind of a double impact in that it actually made them really not enjoy or find pleasure in their sex relationships. What was also interesting was that we looked at factors that weren't associated with it, and clinic wasn't associated with comorbid substance use. Interestingly, being a smoker or a history of sexual trauma weren't a factor either. But what was a very important finding, because we did ask people, where they like support with this, and the vast majority of people, 87% of people, said that they would like mental health services to offer them support in managing sexual dysfunction. And I do think what we're going to do is in the next, this webinar is really kind of being quite descriptive about about sexual health and the components of it. And in the subsequent webinar in 2 weeks' time, we're going to talk more about the management and how you actually kind of manage these scenarios. And I'll do that by illustrating with a number of kind of clinical vignettes. So there are strategies there's a limited number of strategies for managing it, but we will talk through about what's available in kind of current guidelines. I might just check and see if there are any particular questions on sexual function. Before we move on to the next, which will be high-risk sexual behaviours. No, none there. Okay. So the next part we're going to talk about is high-risk sexual behaviours. And as we've already identified, that adolescence and early adulthood is a period of increased risk for both mental health disorders, but also engaging in high-risk sexual behaviours. And there's been research done on both these factors, but not in the actual crossover. So so there's been very little research done in the young people who have mental health disorders on their kind of high-risk sexual behaviours. What we do know is the very limited research has demonstrated that young people do engage in higher risk-taking behaviour with regards to sex, such as having a higher number of partners or earlier age of engagement as well. So within this study, we asked about sexual activity. So with that, the mean age of sexual debut was 16, and we interviewed over 100 people, and nearly 78% had been previously sexually active. And they also report that a strong majority of people had been regularly sexually active, and with 63% in the last month. And also that a number of them also had a number of partners, with 36% having more than 3 partners in the last 12 months. We asked about contraception, and only 36% were consistently using barrier contraception, and 37% had used a non-barrier contraception. But obviously, that means that about 63% who weren't using barrier contraception are open to contracting STIs if they don't know the history of their partners. And also what we found is that it was approximately about 40% of people were using no form of contraception at all, despite being regularly sexually active. And when we looked and asked about the consequences or sequelae of this, and what we, again, this was a very striking finding. Considering the age group of the people that we see, which are between the ages of 15 and 24, that over a quarter of young people had been pregnant, or their partners. We did ask males whether their partners had been pregnant, but that represents just a very small number. I think of those numbers, about just 2 or 3. The vast majority of those pregnancies were unplanned, and we also saw that there was a high rate of terminations and also miscarriages within that group. So 45% of people had terminations of their pregnancy, and 30% had ended in miscarriages. So I suppose this is important for a variety of reasons. But you can imagine that the young person, they're currently attending a mental health service, that an additional stress such as an unplanned pregnancy, how that would further impact upon their mental state, also in their relationships. And I suppose what it really does talk about, I suppose, demonstrate to us that we need to become very proactive about this, and we need to talk to young people about contraception. And again, this needs to be determined at a service level, but whether you have, where you make it easy for young people to access contraception. So for example, do you have access to condoms in the service, or do you have links with a sexual health practice that you can easily refer people to, or that they can access GPs. So questions just come in that the presentation really highlights a link with smoking and sexual problems. This could be an effective lever for clinicians to get young people to look at their smoking. Absolutely, and again, this probably be something we'll talk about in the management of it. But because when young people present with sexual functioning, they're going to require actually a number of investigations to look at potential causes, because we don't want to automatically assume that it's related to the disorder or the medication, because there can be other medical disorders that present with sexual dysfunction, such as diabetes, and it can also be an effect, a result of the smoking. So this is a good opportunity to actually intervene, and it's to talk to people about healthy diet, to screen them for diabetes, but also talking about smoking. And I think it's very important. And this came up just yesterday for me in a clinical scenario when I was someone had reported sexual dysfunction as a result of medication, most likely, but also smokes heavily. When we talked about that, that was again more motivation to actually reduce down the amount of smoking. It's also talking that this can impact longer term as well. So it's more common for smoking to have an effect, like in people outside older than the age group we see. So absolutely, this can be a real good opportunity to intervene about smoking and general kind of good health advice. Sorry, I think a question's come in. So we'll just pass it over. And also the other consequence that we see from people not using contraception is obviously rates of sexually transmitted infections. And what we saw is that not everybody, but nearly 70% or 68% of young people had been sexually active, had been tested for an STI. And of those who had been tested, just over a quarter actually tested positive. The most common STIs reported were chlamydia and gonorrhea and genital warts. Obviously, some of the STIs can be asymptomatic, so it's important to encourage young people to receive screening and to kind of be engaged with either the GP or sexual health service to look for this. And other factors that we see that it can lead to vulnerability is the use of drugs and alcohol during sex. And what we saw in our group was that approximately 15% of young people frequently use alcohol or cannabis during sex, and this puts them in a more vulnerable position. Now, so I just had a question come in, which is that the pregnancy numbers are staggering, which I agree. We were very shocked about that, and it's made us really kind of realize that we have to address this topic. So this is what are the barriers clinicians talk to young people about contraception? Are they too busy, embarrassed, or or assume others have done it? Yeah, I think it's a very good question. And I think barriers to addressing sexual health is a big factor. And I think the person who put in the question has identified that lots of times it can be about embarrassment. And whenever I do this training, when I do it with clinicians in the room, I always talk about that, usually when this has been addressed, the most embarrassed person is usually the doctor, followed by the clinician, and least so by the young person who is just glad that it's actually been addressed. And I think that the other thing is that not all young people actually put two and two together. They mightn't actually know. They mightn't have been informed that, for example, sexual dysfunction related to the medication, and this comes up regularly in clinical practice for me, and it can have a big impact on people's relationships. So actually, even just having a discussion about it can really relieve people's concerns. It can relieve concerns of the partners of the young people coming in for assessment and give them a better understanding of why the person's having difficulties. And we will talk more about kind of barriers at the next talk about how we can address all these things. The other thing about it is I think clinicians can feel uncertain about their role and also about their kind of legal responsibilities as well. So especially if they're seeing people who are under the age of 18, they can be uncertain about whether they whether they're allowed to talk to young people, or whether whether it's actually within their role on what they can and cannot do, in particular in that group who are under age 18. So while I was answering a question, I have left up some of the answers that some people asked, because we did ask young people, how much do you want the mental health service to be involved in your sexual health? And people said 55% said yes, we want the mental health team to play a role. But actually, when we asked more specific questions, the rates were much higher. So, for example, 90%, the vast majority, said that they wanted advice around contraception. Even nearly 90% said that they wanted to be able to access prescriptions for contraception in the same place. So whether we have a one-stop shop for sexual health and mental health, screening, also treatment, certainly kind of managing sexual dysfunction, and with support regarding sexual identity and support regarding sexual abuse. The vast majority say that they would like the service to address this. The question could come in as being, are STI rates at 25% significantly higher than young people in the community who are not attending mental health services? They are. Now, it's very difficult to get a comparison sample in our particular age group from 15 to 24. There's very good statistics from the secondary school surveys, and they found lower rates than in this. So it seems that the young people with mental health disorders have much higher rates. I can't recall offhand what the rates are, and also they are also younger population because they're secondary school students as well. So just give a brief summary of the sexual health study that we did. We saw that there's a diverse group in terms of sexual identity and gender identity. Sexual dysfunction is very common, is associated with more negative experience of sex and also poor adherence to medication. High-risk sexual behaviour is common, as well as a consequence of sequelae. And also sexual health is not specific to one diagnostic group. So this is a youth mental health issue, not just a depression issue, etc., or psychosis. So it's for across all disorders. Now, we mentioned earlier about screening. So as a result of the study, we're looking at how we can effectively screen for sexual health at Orygen Youth Health and how it can be done. And we're at the moment piloting a physical and sexual health questionnaire that we give to young people to complete on entry into the service. It's been piloted within one of the clinics. And really what these really are prompts to for the clinician to kind of start the discussion. And really in screening instruments, you don't want to have kind of detailed questions. What you want certainly are kind of are prompting questions. But also it really should be that sexual health history should form part of a mental health assessment. And so clinicians should be aware that this should psychosocial psychosexual development is an important aspect in developmental history, and really we should be asking directly about it. We need to make sure that we inform young people about the potential side effect of sexual dysfunction with medications. And whether we assess, again, it can be determined at a clinician or a service level about how we assess that. but certainly it can be done with questionnaires or by direct questioning. But it is something that needs to be addressed. And I think it can have benefits. It can have multiple benefits, both in kind of, I suppose, having, if a person experiences those side effects, leading to a better understanding of it and why it's there, reassurance that it does resolve when the medication is stopped, and that it is related to the medication, because often it cause a lot of relationship difficulties. And also young people, the high rates of high-risk sexual behaviour and the consequences are very, very high, and young people need to be asked directly about high-risk sexual behaviour. And these should include things like also whether they work in the sex industry as well. It's very common for us to see young people who have engaged in the sex industry to attend mental health services. And sexual health is something, it's not just something we do when someone enters a service and then the box is ticked. This is something that requires ongoing assessment and also to be addressed regularly throughout a person's episode of care. Because it might be only when a young person develops trust with their clinicians, they will actually reveal things as well, discuss things as well. I think someone asked about the questionnaire that we used within the study. This is part of the sexual functioning questionnaire that we used. It is a research tool, and I think it's important to say that there are a number of limitations to it. As with a lot of the research, it has a wrong emphasis mainly on males and really kind of neglects questions very specifically for females. And also some of the questions, the feedback we received from young people was that some of the questions were very blunt and not very appropriate for young people. Development of a kind of a sexual function questionnaire is something we've kind of put on our to-do list at Orygen within the group who've looked at sexual health. But one of the things we want to develop is an instrument that's inclusive for people of all sexual identities and also gender identities. So I think it'll require a lot of work to make a good instrument. But at the moment, there's a limited number of instruments, but this is the one that we did use, albeit with its kind of limitations. The author's name is Smith, and it was published in the British Journal of Psychiatry in 2002, so it can be accessed from that. There's some other resources that are available. There's a clinical practice in early psychosis. We've mainly focused on early psychosis, but actually there's a number of factors within this resources developed by Orygen. It would relate to other mental health sources, some general advice anyway within that. And that's if you Google Orygen and sexual health, that should come up. If not, it'll be available on the website and under the skills and knowledge. It's also a very good resource that was developed with Orygen Youth Health, the clinical program. Catherine Monson was involved in developing this in collaboration with a number of different organisations, the Rainbow Network and Family Planning Victoria. This is available online with the Rainbow Network. If you Google, it's called Beyond Awkward. It's a resource for clinicians on how to address sexual identity and also gender identity and diversity. Questions that come in: what about modern problems such as sexting? Are young people with mental health disorders more vulnerable than others in regards to sexting? Well, absolutely. It's not just sexting, or there's a number of factors in regards to social media where people are vulnerable. There has been a review on it, and I think it did demonstrate that there can be vulnerabilities. It can lead to psychological stress and certain contributing factor. I'm not sure about whether the young people with mental health disorders. I'll have to check the research on that, and I can bring it up at the next webinar. It's a good question. But certainly, I think that in the last 10 years, with a lot more social media, the young people's engagement in social media and also sexual activity the two have merged, and it makes it very complicated, and there's potential for young people to be in very vulnerable positions in regards to this. And also what I'd like to do is just acknowledge the people who were involved in the sexual health study. It was largely took place last year. One paper has been published from it in psychiatry research, and also there's another paper on high-risk sexual behaviours, which is currently under review at the moment. But I think that was an important study that highlight a number of issues that we're now going to look at, see, well, how do we address the issues? How do we address the issues that have kind of arisen, that we've become aware of as a result of this study? And what I'm going to do in the next webinar is address and look and see how the management of sexual health in young people, and illustrate that with kind of clinical vignettes. So I think I might check and see if there's any further questions. We've got a few last minutes, if there's any last questions. No, I think that's it. So thank you very much for your time and attention, and I hope to see you at the next webinar on this topic.
Thanks, Brian. And I think everybody would probably agree that was a really fascinating thing, even though I've heard some of that before. I think every time I hear some of those statistics, I'm I guess, staggered, as one of the questions sort of said, and reminded that there's a lot to do in this area, and it's important that we include it as part of the standard clinical practice that we engage in. Just to finish up, I'd just like to remind people that we have a range of workshops available on our national training calendar, and we can tailor these workshops to people's organisations if that would be something that people would be interested in, and or deliver them at your workplace as well. So if you'd like to inquire about that, you can see the email address there, and we'd be very happy to discuss the needs of your particular organisation and the training services that we might be able to provide to you. There's no further questions for Brian, but I will just remind you that Brian will be back with the final webinar in this series on young people with mental ill health and sexual problems and sexual health in 2 weeks. So if you'd like to go and sign up for that, you can go to the website to sign up to the finals in the series. It'll be on the 25th of May at 2 p.m. Eastern Time. And finally, just to thank you for your attendance today, and we hope you found this information valuable. Remind you that the webinar's been recorded, and it will be up on the website in probably about 2 weeks from now. As I said at the start, there'll be an email sent around to people letting you know when it's available to watch. Finally, you'll get a certificate of participation, and we'll also ask you to fill in a brief evaluation shortly. And we really would like you to fill that evaluation in, because we do value the feedback you provide, so that we can hopefully provide better webinars as we go into the future. Thanks very much.